Okay. Now we are going to start the keynote lecture 4. Good morning, ladies and gentlemen. In this keynote lecture, we have invited Professor Fung Yuen from the Hong Kong University of Hong Kong, and as you know, he is a very famous hepatologist, and he is one of the top international renowned researchers in the field of hepatitis B, and he now published more than 500 papers in the world-renowned medical journals, including New England Journal of Medicine, Lancet, and et al. And his research field is hepatitis B or the HCC. And today, the topic of his talk is strategies for terminating HBV-related HCC. We are very happy to have you. Please start your lecture.
Thank you, Chairman. Let me share my screen. Yes, I think you can see my screen, right?
Okay, we can see.
Thank you. First of all, I would like to sincerely thank the organizing committee of APASL Single Topic Conference for inviting me to talk on this topic entitled Strategies for Terminating HBV-related HCC. And obviously, the most effective strategy is hepatitis B vaccination. But then for existing hepatitis B patients, how can we further reduce the risk of HCC? We know that there are several host and viral factors for development of HCC. And among them, HBV DNA may be the most susceptible factor for us to control the virus and then reduce HCC risk. And we also know that increasing HBV DNA would have increasing risk of HCC in a positive proportional manner. Therefore, it is very logical and reasonable to reduce HCC risk by suppressing HBV DNA levels in our patients. Irrespective of whether the baseline HBV DNA levels are high or low, practically all patients who received 5 years of nucleoside analogs would have undetectable HBV DNA, usually measured by commercial assays with a lower limit of quantification of 20 IU per ml. Translating the viral suppression into clinical outcome, the long-term nucleoside analogs can reduce the development of HCC. We can see that patients treated with entecavir have a significantly lower incidence of HCC compared to control patients. With all this established facts in mind, anything else we can obtain from nucleoside analogs, in addition to the HBV DNA suppression, which have been the mainstay of treatment for the last 2 decades. In fact, there are 3 interesting recent studies with novel findings about nucleoside analogs published recently. One examined the significance of residual viremia in patients on nucleoside analogs. The other 2 examined the effect of nucleoside analogs on HBV genome integration and hepatocyte clonal expansion. I'm going to present these 3 studies with the hope to reiterate our interest in nucleoside analogs treatment for hepatitis B disease in the context of reducing the risk of HCC development. So the first study, a difference in viremia levels in nucleoside analog treated patients with and without HCC development. The aim of this study was to determine whether residual HBV DNA and RNA levels measured by a highly sensitive assay were associated with a higher risk of HCC development in patients who are already having undetectable HBDNA defined or measured by the commercial assays. We recruited, in this study, we recruited 104 patients with undetectable HBDNA under leukocyte analog treatment. Of these, 52 had HCC, and the remaining 52 who had no HCC were matched with the HCC group in terms of the age, gender, cirrhosis status, and the duration of anti-GFR treatment. Samples more than 2 years, 1 to 2 years, or less than 1 year before HCC diagnosis or at the last follow-up in the control group were retrieved for measuring the residual HBDNA and HBV RNA by highly sensitive assays. The lower limit of detection for both HBDNA and RNA were 10 RU per ml, with a lower limit of quantification of around 52 RU per ml. We find that leukocyte-treated patients who developed HCC had a significantly higher level of HBDNA and HBV RNA 2 years before the HCC development compared to the control group who were also treated with leukocyte analogs without the development of HCC. The median HBDNA levels were 1.7 log for patients who develop HCC compared to undetectable level by the highly sensitive assays in patients who did not develop HCC. The HBDNA was quantifiable or detectable in 61% of patients with HCC compared to only 35% of patients without HCC. The median HBV RNA levels were 2 log RU per ml for patients who developed HCC compared to 1.7 log in patients who did not develop HCC. HBV RNA was quantifiable or detectable in 90% of patients with HCC compared to 63% of patients without HCC. So in summary, in hepatitis B patients on leukocyte analog with HBDNA lower than the quantifiable level by the standard assay, we find that 61% and 90% had detectable quantifiable HBDNA and pgenomic RNA by highly sensitive assays, respectively. And we also confirmed that residual viremia in patients who are on leukocyte analogs is associated with HCC development. The implication is that we need additional viral genome suppression therapy to further reduce the risk of HCC in patients who are already receiving leukocyte analogs. One of the examples may be the additional of a core inhibitors being developed recently. Switching to another aspect of leukocyte analog therapy, I want to present to you with the findings of 2 studies which examine the effect of leukocyte analog on HBV integration and or hepatocyte clonal expansion. This study compared 64 patients on 3 years of tenofovir with 55 patients on placebo. At baseline, both groups show positive correlation between HBV integration with HBV RNA levels, surface antigen levels, and core-related antigen levels, but was not with ALT levels. It seems that HBDNA integration is associated or correlated with different viral activities. After 3 years of treatment, HPV integration significantly reduced in tenofovir-treated group, while it remained the same in placebo group. Furthermore, the authors also find that HPV integration positively correlated with the number of dysregulated human genomes. This means that the more the HPV DNA integrations are, the more disruption will be the human genomes, which may be potentially carcinogenic. So we need treatment to reduce HPV DNA integration and hence to decrease the risk of development of HCC. This final study was coming from my center, where we studied the effect of nucleoside analogs on HPV integration after 1 year of treatment, and with some patients having 10 years of treatment with nucleoside analogs. We recruited 28 patients with paired liver biopsies at baseline and 1 year. Of these 28 patients, 7 of them had their third liver biopsy at 10 years of nucleoside analog treatment. After 1 year of nucleoside analogs, there were reductions in all the serum markers, including HPV DNA, surface antigen, and core-related antigen. There were also reductions in intrahepatic HPV DNA and also cccDNA. We also see improvement in ALT levels as well as the liver histology. All these are well-known findings of nucleoside analogs treatment. Further exploratory experiments find that all 28 patients had detectable HPV integration at baseline. As shown in the left lower diagram, these integrations have different hepatocyte clonal size. In addition, we find that integration frequency positively correlated with the maximal hepatocyte clone size, as illustrated in the diagram on your right. This slide shows you the nice reduction of median and individual levels of integration frequency and the maximum hepatocyte clone size after 1 year of nucleoside analogs treatment, shown in the left upper and lower diagrams, and after 10 years of nucleoside analogs treatment, shown in the right upper and lower diagrams respectively. In this slide, the box diagrams represent the hepatocyte clone size changes in all 28 individuals after taking 1 year, and in fact, some taking 10 years of nucleoside analogs. Take my words, most of the patients had reduction of hepatocyte clone size, and this will also reflected by the decrease in the overall median clone size shown in the table below. Concerning the human chromosome site for HPV integration, HPV can integrate nearly all human chromosomes. We need to confirm in the future studies whether chromosome 21 has the highest number of integration, whereas Y chromosome has the least. We also find that HPV integration, even close to the HCC-related genes, can also be reduced by nucleoside analogs. If this is the case, hepatocarcinogenesis due to HPV integration can be partly hindered by nucleoside analog therapy. The remaining question is, through what mechanism nucleoside analogs reduce HPV DNA integration? We know that integrated HPV DNA was not the direct target of the nucleoside analogs. Some indirect mechanisms are proposed here, including nucleoside analogs reduce the double-stranded DNA that is the precursor of HBV DNA integration, the dilutional effect resulting from cell division during hepatocyte turnover, with the nucleoside analogs preventing de novo infection of the newly generated hepatocytes. Nucleoside analogs induces apoptosis of HBV integrated Hep2 cell line experiments. Whether nucleoside analogs directly inhibits the proliferation of HBV integrated hepatocytes in vivo remains to be studied. So, ladies and gentlemen, I would like to conclude by saying that in patients on nucleoside analogs, residual levels of HBV DNA and HBV RNA are associated with HCC development. We need more profound HBV DNA and RNA suppression by additional antiviral agents. One of the examples, as I already mentioned, is core protein allosteric modulators. The nucleoside analogs treatment can reduce HBV integration and hepatocyte clonal expansion. And the degree of integration positively correlates with viral activities, dysregulated human genome, and also hepatocyte clonal expansion. So we need to treat patients much earlier than what we are recommended by the treatment guidelines and recommendations if we really want to reduce the HBV integration leading to HCC developments. So with that, I would like to acknowledge all these works to our research team in Queen Mary Hospital and in the University of Hong Kong. And thank you for your attention.
Thank you, Professor Yang, for your beautiful and exciting presentation about the recent findings on the HBV and HCC. And we have a few minutes for discussion. Are there any comments or questions from the floor? Yes, please, Dr. Kurosaki.
Professor Yuen.
Yes.
Okay, microphone is not working.
So it's working. Okay. This is Kurosaki from Musashino Red Cross Hospital. I'm impressed of your presentation about the HBV integration. So suppression of integration may be another target to suppress HCC. And in the last slide, you mentioned that HBV-infected persons who are outside the treatment guideline, it may be the target for the treatment in order to suppress the integration. I totally agree, but selection of patients who should be treated is very difficult. According to various guidelines, aging is one of the criteria for the treatment. And do you think that patients who are outside the guideline but getting old, such as over 30 or 40, it could be a target of treatment to prevent HBV integration?
Thank you for your question. I completely agree with what you suggest. It's because, I mean, if you're looking from the aspect of integration, we know that integration starts very early in early infection. And that means if you linger on too long without intervene the integration, with age, the integration process will, increase. And that would, increase the chance of HCC. So I think, if we are talking about patients who are outside the guidelines recommendation for treatment, if they are already mature, I would think, we have no reservation in suggesting the patient to take nucleoside analogs, because studies show that nucleoside analogs given early will be associated with a decrease in integration. And theoretically, I think it will be very, reasonable to say that early intervention with the reduction of integration will decrease the risk of HCC. So in short, I totally agree. Particularly for patients who are already 30 or 40 years old, even outside the recommended guidelines criteria, then I will still talk to the patients whether they agree to take a medication. Although at this moment we need to tell them we still need to take the medication for for very long term.
Thank you for your opinion.
Okay, are there any comments? May I ask one question? In the first part of your presentation, you mentioned that the residual HBV RNA level is associated with the HCC development after nuke therapy. And in the later part of your presentation, HBV integration decreased during the nuke therapy in the long-term treatment. So are there any relationship between the RNA levels, HBV RNA levels, and the reduction of integration after the nuke therapy? Are there any data or thoughts?
I don't think we have data in correlating the integration with the RNA levels. But then when you think about the source of the epigenomic RNA, we think that the epigenomic RNA will be coming from the cccDNA. So if you measure the RNA in the blood, we are measuring the epigenomic RNA from the cccDNA rather than the integrated DNA. So I would think, although we don't have data, but I would think that that may not have a strong correlation between the integrated DNA and the epigenomic RNA.
Your data suggests that the nuke therapy is not sufficient for the complete elimination of a reduction of HCC development from HBV. So do you think what is needed for the complete reduction of HCC development from HBV infection in the future?
Obviously, as I said, the vaccination is the number one. But then, for patients who are already having the infection, I would think we still drive our idea of getting the loss of surface antigen, and that is a state that the virus is replications is adequately, I would say, adequately under control, and that will further reduce the risk of HCC.
Okay, thank you very much.
Thank you.
Now time is up. So Professor Yuen, thank you very much for your nice presentation. And next time, please come to Japan.
Sure.
Okay.
Thank you.
Thank you very much.
Bye-bye.
Goodbye.
Bye-bye. Bye-bye.
Thank you very much, chairs and lecturers.